Lecture is hemodynamic disorders, thromboembolism, and shock. And today we'll so it's a new set of lectures. There will be, I think, 3 lectures of this topic. So it will fit to us. So hemodynamic disorders, thromboembolism, and shock. So as you already know, what is the circulation system, even from school or from anatomy or histology, and I think. And of course, physiology. In physiology, discussed about hemodynamic function of the body, and now we'll discuss the hemodynamic disorders. And what is the thromboembolism? You heard about it, I guess. Okay, let's start to talk about it. So I want to skip this part of physiology, so you know what is blood circulation system. And I want to start directly from the hyperemia and congestion. So what is a hyperemia and congestion? So hyperemia is a reaction, and congestion is a reaction of our body to some stimuli. So, for example, hyperemia, you remember in inflammation. So hyperemia is a normal event which allows the more intake of blood to the area of inflammation. So so hyperemia might be appeared due to workload of the tissue, or might be due to inflammation or any other stimuli. So pro-inflammatory like stimuli. So it's hyperemia. And hyperemia is made by arterioles, first of all. Keep in mind that arterioles are diluted in the cases of hyperemia, and that's why capillaries, which used to be collapsed in this tissue, they get increased in size. And actually, hyperemia is important in the formation of hyperplasia and hypertrophy. So anytime we can, you remember in previous in necrotic set of classes, we discussed that we have hypertrophy and hyperplasia, and you remember that hypertrophy and hyperplasia, it requires building blocks, it requires energy, and this energy and building blocks are gained by blood, and to allow this just to allow this, to afford these changes in the tissue, we need a larger blood intake, and that's caused by hyperemia. So area which is hyperemic area of the body, so hyperemic tissues will be much more reddish in color, so red in color, and little bit swelled, little bit, but not too much swelled, but a little bit swelled and red in color, and it possesses a high temperature on the surface of that organ. So, and once again, so hyperemia is caused by increased workload, and secondly due to inflammation. And in both of these causes, we need a higher blood circulation in this area, which also causes the changes in tissue. But what is congestion? Congestion, from the word congestion, you understand that congestion is always pathological thing. Congestion is when blood cannot remove from the tissue, cannot be. Sound is okay. Yes, sound is okay. So when blood doesn't leave the tissue, doesn't rid of the tissue, and you remember that arterioles gives oxygen to the tissue, but veins return carbon dioxide to the lungs. Yeah, return carbon dioxide to the blood. And after the tissue, so blood is rich of carbon dioxide and rich of waste products, and congestion of this blood, so causing some adverse effect. So let's talk about it later. So here are some events which are caused by congestion. So let's talk about them. Okay, let's talk about surfaces of hyperemic or congested tissues feel wet and typically ooze blood. On microscopic On microscopic examination, acute pulmonary congestion is marked by blood engorged alveolar capillaries and variable degrees of alveolar septal edema and intraalveolar hemorrhage. In chronic pulmonary congestion, the septa become thickened and fibrotic, and the alveolar spaces contain numerous macrophages laden with hemosiderin. It's heart failure cells. So I don't remember we discussed it or not, but macrophages of lungs, they're known as they're known as alveolar macrophages, and these alveolar macrophages are they can digest a lot of they can digest destroyed RBCs, and due to this, so when congestion happens there, so RBCs can release from the blood vessels into the interstitial space, and the macrophages of lungs they swallow these RBCs, and these macrophages, which contain a lot of iron inside, they are known as heart failure cells. Okay. And for example, we have acute hepatic congestion. The central vein and sinusoids are distended with the blood, and there may even be necrosis of centrally located hepatocytes. So, okay, the periportal hepatocytes, better oxygenated because of their proximity to hepatic arterioles, experience less severe hypoxia and may develop only reversible fatty change. In chronic passive congestion of the liver, the central regions of the hepatic lobules viewed on gross examination are red-brown and slightly depressed owing to cell loss, and are accentuated against the surrounding zones of uncongested TEN, sometimes fatty liver. It's known as a nutmeg liver. So this is and actually, okay, just remember morphologic pattern. So it's nutmeg liver. So because some parts are much more supplied by blood, some parts not, and that's why we see this appearance of nutmeg liver. It's a sign of congestion, of liver congestion. Okay. And microscopically includes centrilobular hepatocyte necrosis, hemorrhage, and hemosiderin-laden macrophages. Also, same as in lungs, macrophages trap the RBCs, and RBC, when destroyed, it forms the hemosiderin, so this brown pigment. So that's why macrophages will be hemosiderin-laden. So, and cells, because of ischemia, they undergo necrosis, and blood vessels due to pressure can rupture and form the hemorrhage. And that's it. Okay. So normal, and what we have to discuss here. Okay. Fluid movement outside of the okay, might be diagram here. Okay, this diagram. So let's talk about this diagram. So normally, so what happens in our circulation system? So you know that we have so blood intake from arterial end, and all the oxygen and nutritional substances and water enters inside the microcirculatory bed in connective tissue which surrounds this blood vessel. So it enters into this, and most of this water returns back with so under the influence of plasma colloid osmotic pressure. Most of this blood, most of this tissue, interstitial fluid returns. But in cases of some changes of colloid osmotic pressure, also due to changes in osmolarity of interstitial space, sometimes water can retain in the interstitial space, and then but we still need to drain this water. Yeah, so we can't allow the water, we can't afford the water to keep in interstitial space. So 1 minute. So what, you trying to message me something? So no one warned me yesterday about the situation in Pakistan. So why is it? Okay, anyway, we are recording this lecture, so anyway you can use it later. So, but now who attend, it's better to attend. So easier for you. Okay, and hydrostatic pressure in interstitial space is increased, and water returns. Water returns in, so comes into the capillary bed, and from capillary bed of lymphatics. So it enters into normal to thoracic duct or eventually to left subclavian duct. So they are moving to this area. So that's normal interaction. But where we have changes, yeah. So so why we have any which factors causing the causing the edema, which causing the congestion causes. So first of all, take a look. So if more water enters inside the capillary bed, if more water enters into the capillary bed, it might be caused by hyposmotic edema. It might be caused by hydrostatic pressure, increased hydrostatic pressure inside the blood. So might be caused by swelling due to inflammation. Then gaps appeared in the arterial wall, arterial wall, and then it enters into interstitial space. Okay. Secondary, increased osmotic pressure in the interstitial space. It also can cause the attraction of more water to this area. Okay, and then also it can be might be not returned, so because of decreased osmotic pressure inside the blood, decreased osmotic pressure inside the blood. So, and due to this, so liquid is collected in the air in the interstitial space. And I said one of reason is inflammation here. Yeah. So and fluid collection in the interstitial space must be returned into the bloodstream through the lymphatic capillaries, and they entered into the and through the lymphatic capillaries it enters into the thoracic duct, and then as you remember, thoracic duct returns back in subclavian vein, to left subclavian vein, and all of this excessive fluid enters into the blood. But main idea that interstitial, so if there will be bacteria in interstitial space due to inflammation, yeah, so they have checkpoints along these lymphatics. They are known as lymph nodes. So first of all, lymph nodules and lymph nodes, and then only after a few lymph nodes, this fluid might enter into the bloodstream. So it's like purification of this lymphatics required for this, but it's a point of other discussion. But main idea is that fluid has to be returned. But and what causes the so what might cause the edema? So first of all, it's increased blood flow in this area, and we discussed in inflammation. So increased blood intake, so due to inflammation, causing the edema. It's one of sign of inflammation. Yes, edema is swelling. Okay, secondary, it also might cause, so, but how congestion works? Congestion works when we have interruption of blood flow in a venous part. So when some thrombi or so any clot, or might be any mass which appeared, or might be just your own body parts, so they can collapse this vein, and due to this blood cannot return into the bloodstream, and then it causes a congestion in this area. So congestion is appeared like blue, like bruises, yeah. So in cells, so in organs. So take a look. It's known as blue red color. It's cyanosis, and it's a signal of congestion. But red appearance is hyperemia, so keep it in mind. But in both of them, so much more amount of blood will be present in a tissue. Okay, so let's talk about edema. Yeah, Approximately 60% of lean body weight is water, two-thirds of which is intracellular. Most of the remaining water is found in extracellular compartments in the form of interstitial fluid. Only 5% of the body's water is in blood plasma. As noted earlier, edema is an accumulation of interstitial fluid within tissues. For example, when in cavities, so when same water enters into the cavities by the transudation, it is known as hydrothorax if efflux goes in a pleural cavity. So hydropericardium if efflux goes into pericardial cavity, and also it is known as ascites. Yeah, so hydroperitoneum or ascites. It's happened when we have congestion in related organs. Yeah, in the digestive tract or in respiratory tract or directly inside the heart. So okay, but sometimes it might be generalized, and we have efflux in all of these organs. It's known as generalized edema, so it's known as anasarca. Anasarca. So please remember this term. Anasarca is a generalized edema. So when we can see all of this hydrothorax, hydropericardium, and ascites, and also tissue, and in all interstitial spaces, you will find a lot of water. It's anasarca. So how it's so let's discuss later. It's marked by profound swelling of subcutaneous tissues and accumulation of fluid in body cavities, as I said before. So later we'll talk about causes of edema. So mechanism of inflammatory edema are largely related to increased vascular permeability, as I said before. Okay, let's talk about this. So impaired venous return. So that's impaired venous return is the main cause. So impaired venous return, it is congestion. So keep it in mind, it's congestion. And impaired venous return, and it causes congestive fire. It's caused by congestive heart failure. Congestive heart failure, constrictive pericarditis. So when the fluid of pericardium so impairs the normal contraction of the heart. Ascites, which is caused by liver cirrhosis, and if you remember the structure of hepatic lobule, you remember that in liver cirrhosis, connective tissue will collapse this portal venules, and due to this in portal vein we can see the increased, so we can see congestion in portal vein, and portal vein, as you remember, takes blood from the digestive tract, from the peritoneal cavity, from all most of organs of peritoneal cavity, from all the organs of peritoneal cavity, they are collected by portal vein, and that's why congestion of portal vein always causing the ascites. Then venous obstruction or compression. So it might be caused. So one of example of venous obstruction or compression, it is when you travel by plane. So when you sit for a long time in a plane, and for example more than 5 hours, in a row, so veins of your veins of legs, so let's name it like legs, veins of legs, they are collapsed. And that's not bad in a few minutes, yes, but if you sit for a few hours in a row without movement, like it's in non-comfortable airplane, so in a plane, so you see what happens. So actually blood cannot return. And when you remember it, when you stand up after the sitting for a long time, you feel the tingling in your legs. Yeah, so it's happened because of decreased oxygen supply to this area, because congestion doesn't allow more arterial blood to enter into the legs, and it causes all these effects like venous obstruction or compression. It also leads to other outcomes, so we'll discuss a little later. It leads to thrombosis too, so we will discuss it after the topic of thrombosis. Okay, and finally thrombosis of veins. So when thrombi might appear, so not only in arteries, thrombi might appear in veins also, and they can obstruct the return of blood. Then external pressure. So like mass, yeah, that's a better. So example of airplane is a better explanation here. Lower extremity inactivity with prolonged dependency. So similar. So main idea is that veins are collapsed. So how it happened, so doesn't matter. Okay, what causes the how edema is caused by arterial dilation? So first of all, it's heat and neurohumoral dysregulation. So due to this, cause the arterial dilation and more fluid efflux into this area. So heat itself also allows us to pass water in this area. Okay, and also reduced plasma osmotic pressure. It's known as hypoproteinemia. So you remember that most of plasma proteins, they are produced in the liver, and it's in cirrhosis of liver, so causes the decreased formation of proteins, and also along with it, so it causes the obstruction of veins, and it causes, first of all, it causes ascites, but also along with it, it causes other types of swellings. So because decrease the amount of proteins in the blood, so causing the decreased colloid osmotic pressure. And this colloid osmotic pressure, it keeps the water inside the blood vessels. But decrease that when it's decreased, so colloid osmotic pressure in the interstitial space is higher than in the blood. That's why if it's higher than in the blood, so of course all the liquid by passive transport enters into the interstitial space. Okay, liver cirrhosis then might be caused by malnutrition. So when your body doesn't get enough proteins, doesn't get enough vitamins to produce proteins, or any other cause of decreased amount of proteins which are produced by liver. Due to decreased intake of food, so it causes a decreased protein synthesis in the liver. So it's caused by malnutrition. And you can see this people, so might be you've seen this starving people in Africa, yeah, so starving children in Africa. If you watch them, so they are very thin, but their stomach is very high, yeah, so very large. So I can show it. So, oh no, I can show it. So it'll take too much time. But so all of you remember this BBC video, yeah, that when people show the children of 5 years with a very huge stomach, yeah, so huge stomach, but hands and legs are very thin. So it's actually happened due to decreased protein level in the blood, and that's why it causes the swelling of the peritoneal cavity. Then protein losing gastroenteropathy. Protein losing gastroenteropathy when digestive tract doesn't absorb the proteins. Okay, and liver cirrhosis, malnutrition, and protein losing gastroenteropathy, it's a failure of production of proteins. But we have protein losing glomerulopathies. So in kidneys, so you remember the glomerular apparatus, and in glomerular apparatus we have a filtration sheath. And this filtration sheath, they don't allow protein passage through it. Protein cannot so normally proteins cannot pass through this into the primary urine, but if we have glomerulopathy, so this filtration slit is became present with holes inside it, and proteins easily pass through this, and it causes nephrotic syndrome. So later in urinary system we'll discuss it, of course, but now you have to remember this. And due to this nephropathies, albumin of blood is lost in large amount, more than 3 grams a day. It's a very large amount, so sometimes more. And due to this, proteins of plasma are reduced, and also causes a swelling there. Okay. Then we have lymphatic obstruction. Lymphatic obstruction might be caused inflammatory. So, which, for example, you have, okay, just imagine your finger. Yeah, so your finger get inflamed. So in your finger you have some bacteria, and then by lymphatic capillaries it enters into the ankle joint lymphatics, for example, ankle joint lymphatics, lymphatic nodes, and this lymphatic node is getting inflamed due to this bacteria, and this is a role of this lymph nodes. They interrupt the uh, passing of lymph from the area of infected area to the blood, and that's main purpose of this lymph nodes. And of course, it causes a congestion of lymph fluid, and that causes the lymphatic obstruction. Of course, we will see the edema in this area. Okay, neoplastic, similar process, but instead of bacteria, you just change the word bacteria into the word of neoplasm. So some neoplasm, or so usually cancer, metastatic damaging by cancer cells of cancer cells, they entered into the lymphatic capillaries and travel through this and enter into the lymph nodes. And they also occupy the space in lymph nodes and causing the neoplastic edema. So, for example, yeah, axial. Yeah, you heard about axial lymphatic nodes, yeah, and they are damaged by, for example, breast cancer. And in breast cancer with metastasis, we will always see the swelling of hand, because it's causing the so it's one of, sometimes it's a first sign of breast cancer if a patient never seen it before, never mentioned that she has any tumors in her breast. So sometimes swelling of the hand is a sign that she has a metastasis of breast cancer. Okay, post-surgical. So post-surgically, actually, after the removing of breast cancer, so in cases of in cases we have positive biopsy for cancer of breast cancer, we have to remove the entire breast gland, and also lymph nodes, axial lymph nodes. And sometimes, when too excessive, 1 minute. Okay, and if after any surgical procedure, so which causes the removing of lymph nodes, so it might cause the lymphatic obstruction after this. So, and post irradiation, so it's actually due to, so what's post irradiation? Okay, we'll discuss it later, I think. Then sodium retention. So sodium retention is happened. So due to sodium retention, so you remember it's caused by excessive salt intake with renal insufficiency. So we can't remove the sodium from the body, and it causes an increased osmotic pressure inside our blood. And also keeping of more water inside the blood. Increased tubular reabsorption of sodium. So tubular reabsorption of sodium is controlled by antidiuretic hormone. Then renal hyperperfusion. Renal hyperperfusion, so it's decreased the amount of blood entering into the kidney, and that's why sodium is not removed from the body. Increased renin, angiotensin, aldosterone secretion. So due to them, so it returns sodium back into the bloodstream, and that's why also water retained. And due to sodium retention, so more water present inside the blood, and hydrostatic pressure is increased. And due to this, swellings are more common in the tissues. So, and also inflammation. So inflammation itself, not only inflammatory and lymphatic obstruction, but inflammation itself causes the edema. It might be acute inflammation, chronic inflammation, and in time of angiogenesis, it also present. Okay, How edema is formed by increased hydrostatic pressure, I think it's no time to explain. It's too obvious thing to discuss. Reduced plasma osmotic pressure also explained it. So when we have decreased plasma protein levels, so it causes the efflux of plasma components into interstitial space. And it caused by both its nephrotic syndrome, liver failure, and malnutrition. And then lymphatic obstruction. So have you heard about lymphatic obstruction? So caused by filariasis. So in case of filariasis disease, so we have specific appearance. It's yeah, it causes a disease known as elephantiasis. So my request to you, so now after the lecture you can check the Google and find the diagrams of elephantiasis patients, and you will remember this. So because as I know, in tropical countries as Pakistan is, so you can find so this filariasis disease, and they can and this parasitic infection can occupy the lymphatic vessels, and due to this lymphatic vessel obstruction, it causes the edema there. Okay, so sodium and water retention I already explained. So let's talk about morphology. Morphology is so it's visible by subcutaneous edema. It can be diffuse, but usually accumulates preferentially in parts of the body positioned the greatest distance below the heart, where hydrostatic pressure are highest. So in cases of okay, that's about subcutaneous edema. Usually, subcutaneous edema is happened. Usually, it's due to heart failure. So heart failure, so not excessive, but heart failure is present. And when you usually you are in a vertical position, yeah. So your head is on tip and legs are down. And and after the lifetime, after the day of the life, so all the swellings are occurred in the hands. I mean, in the hands, and also in the feet. Also in the feet. So that's subcutaneous edema. So it is present peripheral to the heart. So down to the heart. It's happened due to hydrostatic pressure. But it also can be diffuse. When it's diffuse, it's it's typically talk to us about nephrotic syndrome, or decreased protein amount inside the blood. So it might be caused by renal dysfunction, or also caused by liver dysfunction, kidney dysfunction, or renal and liver dysfunction. But anyway, we have this edema is named as hypoosmotic edema, hypoproteinic, so hypoalbumin edema. Okay, but also sometimes it causes brain edema. So about the brain edema we'll discuss in a responsible topic in nervous system pathology. I think it will be only in the third year. Okay, clinical features is not our task, so that's depends on location. Of course, edema impairs the functioning of the organ, so that's why we'll discuss it in a relative topic of and edema. So you have to remember that edema might be present in every organ of the body, almost every organ. Okay, hemorrhage. So what is hemorrhage? So by definition, so let's talk about definition, but I had definitions, but at least we must to name this. Hemorrhage, defined as the extravasation of blood from vessels, is most often the result of damage to blood vessels or defective clot formation. So so take a look. So always we have some damage of the blood vessel, always, and normally. So even a small damage of blood vessel, it must be followed with a clot formation. So how it is formed, so we'll discuss, I think it's in next lecture. Yeah, I think it's next lecture. But hemorrhage, we have hemorrhage are different. They might be capillary bleeding, so they're present in chronically congested tissues. They also might cause by trauma, atherosclerosis. So what is atherosclerosis? We will discuss in next semester, I guess. Due to inflammation, due to neoplastic erosion. Vessel. So yeah, neoplastic erosion of vessel wall also may lead to a hemorrhage, which may be extensive in the affected vessel in a large vein or artery. So anyway, so you see, hemorrhage is present when we have lesion of artery, so lesion of blood vessel, any blood vessel, doesn't matter, it's artery, arteriole, capillary, venule, or vein. So any of these then cause hemorrhage. So it's leakaging of blood. So if we have leakage of blood, so it doesn't matter outside, inside, but out of blood circulation, it's a hemorrhage. The risk of hemorrhage after a single insignificant injury is increased in a wide variety of clinical disorders collectively called hemorrhagic diathesis. This hemorrhagic diathesis, so we'll discuss them very soon. So I think in next lecture. They have diverse causes, including inherited or acquired defects in the vessel walls, platelets, or coagulation factors, all of which must function properly to ensure homeostasis. So so later in next lecture we'll discuss the factors of hemostasis, and we'll discuss the normal activity of these clotting factors, and then you can figure out what we discuss right now. So hemorrhage may be manifested by different appearances and clinical consequences. So hemorrhage may be external or accumulate within a tissue as hematoma. So hematoma is accumulation of blood inside our cells. So this hematoma, for example, it's hematoma for the skin, they're known as bruises. Yeah. And but massive hematoma, for example, in a brain, they can cause, now let me show this diagram, this. So huge hemorrhages, they can replace the tissues, for example brain tissue. They can and also might cause the death. Of course, it causes the brain edema. So hemorrhage causes the brain edema, and that's causing sometimes causes the death. So what is the number A? It's punctate petechial hemorrhages of the colonic mucosa, a consequence of thrombocytopenia. So that's we will discuss it. What is thrombocytopenia? Hemorrhage, and also hemorrhage might be present inside the body cavities. Inside the thoracic cavity, it's named as hemothorax. Inside the pericardial cavity, it's known as hemopericardium. Inside the peritoneal cavity is hemoperitoneum. And inside the joints, it's named as hemarthrosis. So you understand the formation of this word. Yeah, hem is blood. Yeah, arthrosis, it's joint cavity. So and this hemarthrosis. Extensive hemorrhages can occasionally result in jaundice from the massive breakdown of red cells and hemoglobin. So you remember that the decomposition of RBCs and decomposition of hemoglobin is going through the stage of bilirubin. And bilirubin is yellow in color, and that's why bilirubin, so increased amount of bilirubin causing the jaundice. And so yellowish, so all the, the jaundice, I guess, yeah. So it's usually we think that if we have jaundice, it's somehow related to liver. But in this case, when we have excessive injury of RBCs, so it caused by extra hepatic causes. It's caused by extra hepatic causes. Okay. Frequently common in iron deficiency anemia, blah blah blah. Okay, that's does not lead to iron deficiency. Okay, that's point of next lecture discussion. So next lecture will start with the hemostasis and thrombosis. So what is a normal hemostasis? So it will be a very tough topic. So today is an observational topic of this of the congestion and hyperemia, and also about thrombosis and hemorrhage. But later in next class, get ready for much tougher explanation. So thank you for attention. Any questions you have? Guys, any questions?
Okay.
Yeah.
No, sir.
No, sir.
No questions. Okay, let's check attendance. Mm-hmm. Okay, checked. And then all your comments. I'll compare comments and the real attendance. Okay, thank you. You can go.